Here are some of the treatment options that we use and have come out from the treatment guidelines. So first of all, of course, many patients will have tried anti-inflammatory medicines that they can purchase in the drugstore on their own, ibuprofen or naproxen. And sometimes we'll use the prescribed nonsteroidals. These can be helpful, but in many patients, they're not adequate. We tend to shy away from use of glucocorticoids in PsA, and I would say we try to shy away more than in rheumatoid arthritis. And part of the reason for that is that there have been cases reported of flares of psoriasis occurring after you, say, use a big dose of prednisone for a couple of weeks to treat a flare. Sometimes we'll see an increased amount of psoriasis, as well as all the other complications that arise from chronic glucocorticoid use. So that I want to really emphasize. Occasionally, a steroid injection into a knee or a sacroiliac joint may be just the right thing to settle a single joint down, but try to stay away from chronic steroid use. Over the past, we've used several medicines like methotrexate, which has been a important treatment. And this has been what was mainly used back 30, 40 years ago and up till about the advent of the biologics. There is also use of methotrexate concomitantly with biologic treatments. And so I'll speak to that a bit more in a moment. But many patients don't like methotrexate. They don't like having occasional nausea. They don't like alcohol restriction. And so that's why many of our patients will prefer to use biologic or targeted synthetic DMARDs, as they're called, the oral agents, as monotherapy. Leflunomide is another conventional oral medication that has been used, and occasionally we've used cyclosporin, but not frequently. Really, the landscape of treatment has changed significantly beginning around the year 2000 when we had the first biologic agents, the TNF inhibitor class, etanercept, infliximab, adalimumab, golimumab, and certolizumab, all serially tested and then approved between 2000 and 2010. And I was fortunate enough to be part of this early experimentation with these medications and just was amazed at the transformation that occurred in patients' lives when their arthritis and enthesitis and spondylitis would be controlled, their skin disease would improve, and they would come back in and say, "Doc, this has just changed my life." And it really made such a difference to us as rheumatologists because we were used to holding patients' hands as they gradually destroyed their joints in front of us. And finally, to have treatments that could inhibit structural damage progression, help with fatigue, get people back to work, get people back to enjoying their lives. What a change. After the TNF inhibitors, there came a cascade of other biologic treatments based on what we know about the cellular biology of the disease, including IL-12 and 23 inhibitor, ustekinumab, the IL-17 inhibitors, secukinumab and ixekizumab, IL-23 inhibitors, guselkumab and risankizumab, and the T-cell modulator, abatacept. Also, during that period, there were several oral medication options that were very targeted in their immunologic approach. One, the PDE4 inhibitor apremilast, which was effective in treating both joints and skin. A few tolerability issues at the initial phase of use of the medication with nausea and diarrhea, but otherwise relatively safe. And then what are called the Janus kinase or JAK inhibitor class, tofacitinib and upadacitinib, were tested and then approved for the treatment of psoriatic arthritis. So in this day, we have a real healthy, significant armamentarium of options to treat our patients with. And if we lose response to a medicine, or if the patient doesn't respond well, even initially, then we've got other options. We've got other mechanisms to switch to. So this is the array of options that we have for treatment in this day. Now, in clinical trials, we've got a complex set of domains that we've been speaking about: joints, entheses, dactylitis, spondylitis, skin disease, nail disease. Wow, how do you go about measuring and capturing whether or not you get meaningful change with the treatment? So this is the array of measures that are used in psoriatic arthritis clinical trials. Some of these are measures that physicians will do, such as the feeling the patient's joints for tenderness or swelling, and pressing on the various places where tendons or ligaments that can be inflamed insert into bone, like the Leeds enthesitis index. We palpate at the lateral epicondyle or the medial femoral condyle at the knee, or the Achilles tendon insertion. Dactylitis, we look for fat sausage digits, and so on. But there are also some important composite measures that are noted here, where we put together several items, including tender and swollen joint count, maybe a skin score and an enthesitis score, maybe patient pain, patient global, and come up with a more holistic assessment of disease. And then there are a number of other, including patient-reported outcomes, such as pain, patient global, fatigue, which is a really important symptom in many autoimmune diseases, physical function, participation in meaningful life activity, work, productivity. We always are assessing the skin for evidence of psoriasis and change thereof, as well as assessing nail disease. So very little in the way of laboratory, just a SED rate or CRP noted here. And then, of course, imaging to tell us whether or not we're able to inhibit structural damage progression. Complicated, but comprehensive.
Great. All right. So let's take a look at this. So now we're diving into the specifics of GRAPPA treatment recommendations for each of those domains. And the first one that we're going to start out with is peripheral arthritis. I'm going to kind of walk you through this slide a little bit. You'll see the same format coming up in the subsequent slides. So what you see is that on the left-hand side, we have the peripheral arthritis. And then in those with peripheral arthritis, it's divided into three subtypes, right? So those who are DMARD naive, those who had incomplete response or inadequate response to DMARD or DMARD-IR. And then finally, we have the biologic DMARD experience, which is a third group. And then if you look in the middle of the slide, there's a big kind of purple bar that says recommended for. So this is our recommendations. And then there are strong recommendations, which is the medications that are strongly recommended for those three different types that are listed there. Then there are conditional recommendations, where are the medications that are all still recommended, but maybe with a little less strength there. And then to the right-hand side, you'll see the heading recommended against. So this is an area where you'll see later when we address some other domains, you'll see things listed there. This is an area where we have medications we actually recommend against in a particular for a particular subtype of a domain. So conditional recommend against, meaning, we kind of don't love it. And then strong recommend against means that we definitely don't like it. All right, so let's go to the DMARD naive cohort. So what you see here is that in the DMARD naive cohort, you have a lot of different options. You have your conventional synthetic DMARDs, except for cyclosporin. You have your biologic classes. You have your JAK inhibitor, PDE4. So all those are can be strongly recommended. And in the conditionally recommended for the DMARD naive, you have your NSAIDs, you have your oral you have your oral glucocorticoids or the intralesional, intraarticular injections. And then you have, what about DMARD IR cohort? So in the cohort who did not respond adequately to DMARDs, then the strong recommendation there include TNF inhibitors, your IL-12/23 inhibitor, ustekinumab, your IL-17s, your IL-23 inhibitors, your JAK inhibitors, and PDE4. And then for the conditional category, you still have your, and then with a lesser recommendation, which include the conventional synthetic DMARDs, NSAIDs, your oral or intra-articular glucocorticoids, and your T-cell modulator. And for your biologic, for the third phenotype under peripheral arthritis, in your biologic DMARD experienced, consideration of biologics there, JAK inhibitors, and then for the conditionally recommended, you see that things listed there. So we essentially move the PDE4 inhibitor to the conditionally recommended column when going from DMARD IR to biologic DMARD experienced. And with that, to you, Philip.
In axial disease, there are fewer choices. So we have evidence for benefit from nonsteroidals, physiotherapy, simple analgesics, the TNF inhibitors, the IL-17 inhibitors, and JAK inhibitors. Typically, we use the data from axial spondyloarthritis studies with these types of medications. And if they're successful for that condition, then we use that as a surrogate for psoriatic arthritis spine involvement. The only trial that's been completed in axial PsA is the IL-17 inhibitor secukinumab, so the so-called Maximize trial. There is also a trial underway with the drug guselkumab, known as the STAR study. And the reason for this is that the IL-23 inhibitors, of which guselkumab is one, did not fare well in studies with axial spondyloarthritis. There were failed trials with ustekinumab, an IL-12/23 inhibitor, and risankizumab, an IL-23 inhibitor. But there was some interesting data from a PsA trial, set of PsA trials with guselkumab, which suggested that there might be benefit in axial PsA. And there may be enough difference between axial PsA and axial spondyloarthritis that some additional medicines may work. But so this is important to sort out, does this patient have axial disease, and then use medications that are specifically beneficial.
All right. And then continue with you, Philip.
In enthesitis, we have the following options that are listed here: TNF inhibitors, IL-12/23, IL-17, IL-23, JAK inhibitors, and PDE4 inhibitors. All of these can be helpful. There's a conditional recommendation for methotrexate that used to be felt not to be helpful, but with the data from the SEAM trial, we're now seeing that it can be helpful. This is an important domain, and it's good that we have the options that we do. And then for dactylitis, it's a similar set of options as for enthesitis.
All right. And then for psoriasis, and this is for patients with for psoriatic arthritis with psoriasis, here we have a number of different options for the psoriasis itself. This includes topical therapies, phototherapy, our conventional synthetic DMARDs, all of our biologics here, as well as PDE4 inhibitors and our JAK inhibitors also can treat the psoriasis domain. Conditional recommendation, acitretin can be used, but efficacy is a little bit modest compared to other oral therapies, and certainly more modest compared to our biologics. For nail disease, here is where you see our topical therapies go away because they don't work very well for nail disease, and phototherapy goes away as well. Our biologics work well for our nail disease overall, and also we have data with PDE4 inhibitor there too. And here, JAK inhibitors, in my opinion, also can work well for nail disease. It's in the conditional category. There are other things that are listed in the conditional category for the nail domain. Conditional because we kind of, recommend it with some kind of reservation because they may not work as well. Topical glucocorticoids typically don't work that well. One can try it, but please have very muted expectation for that. And some synthetic systemic DMARDs, methotrexate, have shown to have some nail efficacy. But I would say at this time, if you have moderate to severe psoriatic nail disease, we tend to use biologics in those cases. All right. Now, what if you have patients who have IBD? So we talked about the different domains of psoriatic arthritis, and we're going to layer on top of that certain comorbidities. One thing that you will note is that with patients with Crohn's and ulcerative colitis here, TNF inhibitors are used to ustekinumab. And also, actually, I would say, Philip, nowadays our IL-23 inhibitors should probably be in the strong category because they have been evaluated and have shown to have efficacy against that. So I would say they all work very well. In the conditional category, we have our JAK inhibitors and methotrexates there. Very importantly, if you look all the way to the right, is where we strongly recommend against. We strongly recommend against IL-17 inhibitors because in patients with active Crohn's disease or ulcerative colitis, a small proportion of them can actually get exacerbation of their Crohn's disease or ulcerative colitis with the use of IL-17 inhibitors.
April, I'll just interject here that we've been publishing these guidelines about every 4 to 5 years, but already we can tell that the Crohn's is sort of out of date. We're going to have we have good results with, as you point out, IL-23 inhibitors and JAK inhibitors. So we're hoping to have more frequent updates going along to try to keep up with the times.
Absolutely.
And in terms of uveitis, the key point here is monoclonal TNF inhibitors can be helpful, as well as methotrexate.
Wonderful. And then here we have a summary of the different domains that we talked about. And what you will see underneath each domain are the strongly recommended therapies that we have covered for each of those. And then right below that is if it doesn't work, there are recommendations for what to switch to. So I would say this chart is well worth screenshotting and also maybe put it by your bed. Maybe we can all absorb this by osmosis.
One of the things that has come out of our recommendations is the recognition that we need to take into account the various comorbidities that have been mentioned before about patients. I'm not going to belabor this slide. There's a lot here, but just to use as an example, if a patient is obese and may have fatty liver disease or has a background history of hepatitis, then of course we should use caution or possibly not use drugs that may be hepatotoxic, such as methotrexate or leflunomide. So you see the yellow and reddish color underneath the methotrexate column. And obviously, if a patient has had a history of TB that's not been fully treated, then we should have caution with medicines like the TNF inhibitors. as well as potentially other biologics. So these are important aspects to keep in your mind and make sure that we're taking these into account as we're making choices. In terms of infection risk, we always need to talk to patients about the potential for having serious infection. Because that's been seen in some clinical trials, although with some of the newer agents, such as the IL-17 or IL-23 inhibitors or PDE4 inhibitor, we don't see so much separation from placebo in terms of the rates of serious infection. But this is something always we should take into account. And clinical trials may not give us the full picture because we've excluded patients with important pulmonary or cardiovascular comorbidities that also may put a patient at greater risk, or older patients. So as good docs, we need to keep this in mind and educate our patients about bringing any signs or symptoms of infection to us as soon as possible.
All right. We with our patients with psoriasis and psoriatic arthritis, it would be wonderful if they can be managed in a combined clinic model. And there are several of those around the country. And there are definite benefits to that, especially for the patients who only probably need to make one visit to see both dermatologists and a rheumatologist. But also there are oftentimes real world challenges in executing that. What I would say is that, this day and age, I think the key thing is identifying our psoriatic disease buddy, kind of, a rheum derm. And if you're so lucky to be in Seattle, you have Dr. Mease there. And if you're a dermatologist in the audience, definitely make sure you jot down his contact info. So I believe, outside of the physical combined clinic model, there are many successful ways in which derms and rheums can together co-care for this patient population.